Actually, it's our pleasure to have you today in Boehringer Ingelheim session. Hopefully, it will be interesting and useful for you as well. It's an honor to let me introduce our speaker for the session today, Dr. Jehan Abdullah. Dr. Jehan is a consultant physician and endocrinologist in Bahrain Defensive Hospital in Bahrain. Actually, she has been graduated from Trinity College in Dublin, Ireland. Dr. Jehan also is a member in Saudi Arabia in International Medicine Board. Finally, Dr. Jehan has an endocrine and diabetes fellowship training in Adelaide, Australia. Let us all welcome Dr. Jehan Abdullah.
Thank you. Good morning, ladies and gentlemen. I'm going to talk today about triple protection, understanding the cardiorenal concept. First, I would like to thank Boehringer for organizing this symposium. Despite decades of research into risk reduction strategies, the cardiovascular and renal abnormalities or disease in diabetic patients still are the leading cause of mortality and morbidity in diabetic patients. So given the tight clustering of cardiovascular, renal with metabolic abnormalities, we can think of it as cardiorenal metabolic disease. And this terminology emphasizes with the highly interconnected nature of cardiovascular renal metabolic illnesses. So the cardiorenal metabolic system, they are all interrelated. The heart is the most metabolically demanding organ, susceptible to changes in volume and metabolism. Regulation of energy metabolism by liver, pancreas, and fat is essential for healthy function of organs, especially the heart and kidneys. The kidneys play a key role in glucose and volume homeostasis and blood pressure regulation. So cardiorenal metabolic systems, they're all interrelated. Acute or chronic dysfunction in the heart, kidneys, or metabolic system may induce dysfunction in the others. Each dysfunctional organ has the ability to initiate and perpetuate disease in the other organs, so through hemodynamic, neurohormonal, immunological, biochemical feedback pathways. Type 2 diabetes is a risk factor for diseases related to cardiac renal system. So patients with type 2 diabetes, they have multiple risk factors that contribute to cardiorenal metabolic disease. Like, for example, 55% of our patients, they have non-alcoholic fatty liver disease. Over half of the patients, they are obese. So type 2 diabetes reduces the life expectancy by about 6 years. And type 2 diabetes reduces the life expectancy in patients with cardiorenal comorbidities. So patients with type 2 diabetes are at increased risk of complications such as cardiovascular disease. Approximately 1 in 3 patients with type 2 diabetes, they have cardiovascular disease. There is a 2 to 5-fold increase of hospitalized heart failure in patients with type 2 diabetes. So cardiovascular disease is the leading cause of mortality in diabetic patients. So after all of this, we expect that the life expectancy is reduced in patients with diabetes. For example, if the patient has diabetes plus cardiovascular disease, the life expectancy is reduced by 12 years. If it is only diabetes, the life expectancy is reduced by 6 years. So patients with type 2 diabetes are at increased risk of complications such as coronary kidney disease. CKD affects about 40% of patients with diabetes, and diabetes and hypertension is the cause of more than 80% of a chronic kidney disease or end-stage renal disease. Of course, the life expectancy will be reduced in patients with type 2 diabetes and CKD about 16 years. The presence of CKD increases the risk of cardiovascular morbidity and mortality. Up to 67% of patients with heart failure are they're estimated to have chronic kidney disease. The risk of cardiovascular death increases as kidney function declines. Presence of CKD in patients with heart failure increases by 25 to 28%. So after all of this, the mortality is substantially higher in patients with type 2 diabetes and chronic kidney disease. As you can see here, if it is diabetes alone, the incidence of mortality about 4.1%. But if it is type 2 diabetes with albuminuria and reduced GFR less than 60, the incidence of mortality will be about 47%. So SGLT2 inhibitors and GLP-1 receptor agonists provide benefits across the cardio-renal metabolic system, complementing the effect of standard of care. And this is, if you can see, that SGLT2 inhibitors cause reduction of MACE, major adverse cardiovascular event, cardiovascular death, hospitalized heart failure, hard kidney outcomes, albuminuria, and GFR worsening. And the same GLP-1 that will, the benefit, cardio-renal benefit of GLP-1 includes MACE reduction, cardiovascular death reduction, and reduced albuminuria. EMPIRIC outcome trial. It's a very big study. It's a cardiovascular outcome trial. Was a randomized double-blind placebo-controlled cardiovascular outcome trials. They've enrolled patients, about 7,020 patients from 42 countries. And they have divided them into groups. Some received the placebo and the other group received empagliflozin, 10 milligram and 25 milligram. The primary endpoint was the three-point MACE, which includes cardiovascular death, pre-specified primary endpoint component, cardiovascular death, non-fatal MI, and non-fatal stroke. So the key inclusion and exclusion criteria in this study, they included all patients above the age of 18 years, the HbA1c between 7 and 10 with established cardiovascular disease, at least one of the following, like coronary artery disease, peripheral artery disease, MI, or stroke. And they have excluded patients with GFR less than 30 or acute coronary syndrome, stroke, or TIA within 2 months prior to the informed consent. So the key baseline, the study population was at high risk of cardiovascular events and well controlled for modifiable cardiovascular risk factors. The HbA1c around 8.1, 99% they have established cardiovascular disease. So here in EMPIRIC outcome, cardiovascular disease was broadly defined as coronary artery disease, peripheral artery disease, and or prior events like MI or stroke. And you can see 75% here they have coronary artery disease. EMPIRIC outcome was the first cardiovascular outcome trial to show cardio-renal protection with an anti-diabetic treatment or agent, raising new possibilities in the management of type 2. You can see in the cardiovascular death risk reduction with the group who received empagliflozin was 38%. With hospitalized heart failure, 35% relative risk reduction with the group who received empagliflozin, and the 3-point MACE 14%, with death by any cause 32%, nephropathy 39%, and renal composite by 46%. So cardiovascular death onset of effect, reduced risk of cardiovascular death occurred early and was sustained. It is from the beginning of the trial, you can see it here, and it has sustained throughout the trial. So in summary, empagliflozin, in addition to standard of care, reduced cardiovascular risk and improved overall survival in adults with type 2 diabetes at high risk by reducing relative risk reduction of 3-point MACE by 14%, cardiovascular death by 38%, all cause of mortality 32%, and hospitalized heart failure with 35%. So this is, EMPIRIC was a controlled trial, but we need a trial or a study from a real-world evidence, and this is what we call it EMPRISE. So EMPRISE, it's a real-world evidence study. It's a non-interventional study of cardiovascular effectiveness, safety, healthcare utilization, cost of care of empagliflozin in routine clinical practice, and these are the same like patients that we see in clinical practice. So the background of EMPRISE was the EMPIRIC study, which was published in 2015, and empagliflozin was launched in the United States in 2014. And additional analysis indicated that these effects were consistent across the cardiovascular continuum within the EMPIRIC outcome population. So EMPRISE, they have here divided the patients into groups, about 347,000 patients, more than 18 years of age. 50% of these patients received empagliflozin, and the other 50% received DPP-4 inhibitors. In the other group, 50% received empagliflozin and the other received GLP-1. And they have enrolled here the same patients above 18 years of age, and it is 1-to-1 ratio. So effectiveness outcomes with empagliflozin versus DPP-4 in routine clinical practice. Empagliflozin was associated with reduced hospitalized heart failure in routine clinical practice compared with DPP-4. As you can see the blue dots here in the graph, that empagliflozin reduced the risk of incidence of cardiovascular or hospitalized heart failure. And the effect of empagliflozin versus DPP-4 on hospitalized heart failure was consistent in patients with or without cardiovascular disease. Effectiveness outcome with empagliflozin versus GLP agonist. You can see the cumulative incidence of hospitalized heart failure broad in the group who received empagliflozin in comparison to the group who received GLP-1 was less, and the same thing with heart failure hospitalization, the specific group. So in empiric outcome compared with the placebo, empagliflozin reduced the relative risk reduction of hospitalized heart failure by 35% in patients with type 2 and established cardiovascular already receiving the standard of care. Interim analysis from EMBRISE of patients with type 2 diabetes in routine clinical practice showed that empagliflozin was associated with 44% relative risk reduction of hospitalized heart failure compared with DPP-4 inhibitor, and these results were consistent, and 26% relative risk reduction of hospitalized heart failure compared with GLP-1. So EMBRISE, which includes 3/4 of patients without established cardiovascular disease. You remember EMBARIC, most of the patients they have established cardiovascular disease. So major adverse cardiovascular events is SGLT2 inhibitors and GLP-1 receptor agonists. Cardiovascular outcome trials and cardiorenal trials generally demonstrated MACE risk reduction in patients with type 2 diabetes with SGLT2 inhibitors and here with GLP-1. And even cardiovascular death, only empagliflozin and liraglutide have shown a significant risk reduction in cardiovascular outcome trial in patients with type 2 diabetes. You can see with SGLT2 here, summary of cardiovascular heart failure and kidney outcomes with the drugs used for the management of patients with type 2 diabetes. With SGLT2, there is relative risk reduction in MACE, cardiovascular death, hospitalized heart failure, heart kidney outcomes, albuminuria, and all cause of mortality. In comparison to other medication or drugs, you can see the difference. So SGLT2 inhibitors showed reduced in all type of mortalities, and GLP-1 receptor agonist showed reduced major adverse cardiovascular events, cardiovascular death, albuminuria, and all cause of mortality. So there is evolution of international guidelines in light of emerging cardiovascular outcome trials results. These are the cardiovascular outcome trials, especially EMBARIC was the first cardiovascular outcome trials which had shown that the SGLT2 as a diabetic treatment have a cardiovascular benefit and cardiorenal benefit. Evolution of international guidelines in light of emerging cardiovascular results from here 2015 till 2020, you can see the guidelines has changed. In type 2 diabetes, drug-naive patients with atherosclerotic cardiovascular disease, high or very high cardiovascular risk, you can start as a first-line treatment SGLT2 inhibitors or GLP-1 receptor agonist or metformin. So now SGLT2 and GLP-1, they are considered as a first-line treatment even with drug-naive patients if they are at high risk or very high risk of atherosclerotic cardiovascular disease. And in type 2 diabetes patients on metformin, you can add SGLT2 inhibitors or GLP-1 or continue on monotherapy for patients with atherosclerotic cardiovascular disease or high or very high cardiovascular risk. So a global view about cardiovascular renal metabolic disease needs an integrated approach. And this integrated approach, we need to think about not just the traditional atherosclerosis risk or prevention. We should think about heart failure prevention, renal failure prevention. And with these treatments like SGLT2 inhibitors and GLP-1 receptor agonists, they can facilitate this integrated approach. So understanding the interrelated cardiorenal metabolic system are interrelated. Dysfunction in one organ or system can induce and contribute to dysfunction in the other organs. So type 2 diabetes, cardiovascular disease, heart failure, and CKD are interrelated, and the presence of type 2 diabetes is associated with cardiac and renal disease progression. A holistic approach to type 2 diabetes care is necessary to address the cardiovascular, renal, and metabolic aspects of disease. Guidelines and societies recommend the use of agents with cardiorenal metabolic benefits such as SGLT2 inhibitors and GLP-1 receptor agonists for the treatment of type 2 diabetes. Thank you.
Thank you so much, Dr. Jehan. It's our pleasure to have any questions for Dr. Jehan regarding the management of type 2 diabetic patients you face in your clinic. If even we have an access to the virtual questions, if we receive any. Okay, so far, we would like to thank you, Dr. Jehan, for this interesting, lecture covering most of the aspects of cardiovascular protection, not only managing the diabetes, not only the glycemic control, it's also about whatever beyond to save the patients' lives. So thank you so much for this interesting lecture. Hopefully to see you in another meetings, inshallah.
Thank you.
Thank you, Dr. Jehan.